Good morning, everyone. My name is Leba Kabongo. I'm going to yes, my name is Leba Kabongo. As I said, I thank the Lord. Hello, I thank the Lord, the University of Texila, for giving us this.
Yes, please.
This which personally, based on just two presentations,
breaking, Mr. Lee.
I've learned a lot, and I know that through this, the whole day we will learn a lot of things. So I'm going to present on the understanding of the motivation. My case with the accident emergency department. Yes. So the mortality and morbidity has got to do. Mortality and morbidity has got a goal to reduce the mortality in the department, and also to learn mostly through our own mistakes, because generally we are attending patients, but those patients can also die. We cannot stop death, but we have to learn through our own mistake what had been done. Did we treat the patient correctly or not? So in our department, we attended during 2014, 2015, about 28,000 patients with a mortality rate of nearly 0.4%, and most of them were patients with medical condition and some on palliative care, and about 65% of them were discharged home. And conducted an in-depth analysis of this mortality and morbidity, which we have been conducting every month, and attention to young adults attending the department has been raised, and especially to those with some comorbidities. And we also emphasize management of the HIV/AIDS patient. And also we were thinking about the education of the population, especially the young one, those who are in long life treatment, so for them to adhere correctly to the treatment. So on the background, mortality and morbidity at the emergency department provide an in-depth analysis of each patient who died within the department. So each month we have to go through all those patients. Sometimes it's not possible, but we have to go through all the file of the patient who died, and we tried and see what did we do correctly and what was not done correctly. So as you know, in any hospital worldwide, the accident emergency department is the main entry of the hospital, and which give actually the image of the entire health facility. And death at the level of accident emergency will always require answers to different questions, like why the patient died, what could have been done better, what did we miss, what else, what can we learn through the death of such a patient. So during on my article, I also present one case among the 111, which was quite an alarming case, where it was a young boy who died after trauma, and the patient remained in the department for quite a long time, for more than 12 hours, despite of going immediately for operation. This was something which we are supposed to adjust. So what I did as a methodology, it was a retrospective study, with archival data collection, which we compiled for a period of 1 year, starting from April 2014 to March 2015. The data were collected from the monthly presentation of the mortality and morbidity. As material in the department, we use all the medical record. We have a registration of patient who died in A&E, in accident and emergency. A&E stands for accident and emergency. We have the admission book. We have the triage form where we record information concerning the patient from the nurses and doctors' side, and the patient, the registration for brought-in death, the patient who came in already dead, and also the case presentation for discussion. As a result of my study, first of all, I will start with the F professional. During the period of my study, the department had only 10 medical officers and only 15 nurses, few F auxiliaries, about 5 F auxiliaries, for a mean of 80 patients to be seen on daily basis. And as I said, for the entire year, we have seen about 28,000, roughly 27.4, which came for different reasons to the department. So only 111 patients died, with a very small number of health professionals, which sometimes are always appreciated. That's about 4.4%. 36.7% of patients were admitted in the ward, and the remaining, which is about 65%, were discharged. We also have a certain number of patients which were brought in dead, which is about 0.8%. So in the study, we have presented about 12 tables with patients who died in the department with their diagnosis. We have an overall of 56% of patients who died with medical conditions, and others died with surgical conditions, like 36%. And most of the patients were male, 53%, and female, 47%. Concerning the age, 56% died with on the age of 14 to 49, 46 above 50, and the remaining were pediatric. Acute illness mostly, and less trauma, and the remaining were some few cases of chronic condition and palliative care. So most of our patients came from different area, and in the area which the hospital is situated, we have only clinics. There is no district hospital, and all the district hospital came from other provinces. So in the capital city, we have only one referral hospital with clinics, which explain the number of patients that have been discharged and the number of patients of self-referral. We have 28% self-referral, 42% of patients who came from local clinic, and 30% from district hospital. So in conclusion, the mortality and morbidity at accident and emergency department can be reduced sensibly if most effort are made, especially when it comes to the number of health professionals, and especially when it comes also to the correct referral and the education of the population. And for the past 5 years, as I've been following this mortality, our mortality rate had been less than 0.5%, which we always appreciate, despite of the constraint on the number of health professionals like medical officers and nurses, and also the fact that most doctors who come to the department are junior doctors, just completed their internship, and they have to face this challenging issue with lack of training. So for future step, Being a center of excellence and headlight department at this hospital, we recommended that a trauma team should be established in the hospital, which means, and generally those trauma patients who died, it's because there was no good follow-up. If we have a trauma team, it's very easy for that trauma to be focused on the case and follow the patient correctly and apply a correct management. Also, the staff should be trained. Most of the staff, junior doctors, junior nurses, should be trained in the emergency care. They are not specialists in the department, but they are posted to work in that department. So they have to get some sort of training so that they can improve their management. The shortage of the staff should be also adjusted, and the referral system, the transfer strategy should be also evaluated. So based on the fact that the highest number of patients were medical case, so in the future, on my future perspective, I'm thinking of going to a research and try and understand which kind of diagnosis are leading mostly to death in accident emergency, so that we can provide more teachings, more training to those who are working there, and to prevent good management once those patients arrive in the department, so that we can also reduce
Thank you, Mr.
mortality.
Leba.
So
my wonderful presentation.
this was my short presentation,
we'll go for the question and answer session.
and my reference in the article, the full article, which I submitted to the e-conference management.
Your questions will be sent
Thank you.
to his email ID.